Well, thanks, Randy. It's really a pleasure to be here. At Penn, we are fortunate, seemingly every year, to attract one of your residents to our Pulmonary and Critical Care Fellowship program, and they always set the bar higher and higher, seemingly each and every year. I'm really excited to talk to you about changing choice architecture to improve serious illness care. I promise I will define what I mean by choice architecture at some point. Just by way of sort of stage setting and in some ways disclosures, these are the organizations that we do most of our work with. A big focus of our work is to conduct studies in the contexts and settings in which most Americans receive their care. So large health systems, typically out in the community, a little bit separated from silos of academia. And these are the organizations that support the work that I'll be talking to you about. So this is sort of like a standard motivation slide for almost any talk about serious illness care and palliative care, end-of-life decision-making. Talks about the end-of-life experience in sort of some statistical terms. So about 1 in 3 Medicare beneficiaries dies in a hospital. That's a number that's been declining over time. About 1 in 5 in an ICU. That's been static over time. The last month of life is particularly intensive for Medicare beneficiaries, with about half being admitted to an emergency department, roughly a third in an ICU, and remarkably 20% with a major inpatient surgery in the last 30 days of life. The intensity of this care is felt profoundly by family caregivers or surrogate decision makers, with 1 in 3 developing PTSD or the syndrome of complicated grief. And then there's this number that receives a lot of attention, with 26% of Medicare spending going to patients in the last year of their life. And just by a show of hands, who thinks this number is increasing, decreasing, or staying the same over time? So increasing, staying the same, and decreasing. So this number has not budged by more than 1% up or down in 30 years. It's really remarkable. I don't know of any statistic in healthcare that's been that stable. Now, I don't know if that's too much or too little or just right. But I do know that this is concerning. So this is a figure that actually The Economist produced, because our paper in JAMA Internal Medicine, the graphic editors there aren't quite as good as the ones at The Economist, so I'm showing you this one. This is a study of 200 inpatients in just one setting, the hospital of the University of Pennsylvania. All 200 of these people have life-limiting illnesses, advanced heart failure, metastatic cancer, advanced COPD, the usual suspects of serious illness care. And they're in the hospital. So these are people for whom these potential health states could plausibly be in their foreseeable futures. And we asked them a simple question to rate what these health states would be like in comparison to death. And over on the left, in the red, those are the proportions of people who said that those health states would be worse than death. In the pink, which I think is relevant also, those are people who said those health states would be equivalent to death. And then the blues are different shades of, yeah, I'd rather that than to die. I actually don't think these absolute proportions are very relevant. This is in part a feature of affective forecasting errors, that it's hard to imagine what a state would feel like if we haven't actually felt it quite yet. But the magnitude of people who would find these states dissatisfying, and the probability that many of these people will wind up in those states as a function of the care we provide, is concerning. So if I ever get around to writing a memoir, it's going to be titled this, Confessions of a Hopeful Skeptic. And what I mean by this is I am perhaps problematically skeptical of most data. But I am also hopeful that the future can be much better than the present is in terms of the evidence base around serious illness care. Back in 2015, I wrote this piece that basically condemned the fact that we actually know almost nothing when it comes to improving serious illness care. And then I laid out a few things that give us hope that the future will be better. And indeed, just in the last 4 years since, we have learned many things. Honestly, many of those new insights have come from Randy and the Cambia Palliative Care Center here. And things really are getting better in terms of the evidence base around end-of-life care, slowly but surely. And then more recently, I was lamenting the fact that professional societies are calling for goal-concordant care as a quality measure. This has actually made its way down to quality measurement forums in DC. Many groups have posited that goal-concordant care should be the primary outcome in all trials of serious illness care. These are well-intending propositions, but there's one major problem. We haven't the foggiest idea how to measure whether care is or is not goal-concordant. And so I was lamenting that, but then again, hoping that there may be better ways to do this in the future. I'm not sure if they'll work, but there's promise. So apologies that the formatting shifted a bit and probably in the Mac to PC transition, but hopefully you can appreciate some of these main points that I'd like to share with you about some of the reasons why the status quo is a bit dissatisfying. And they all have to do with normal human psychology. So first, actually this got shifted a bit, but I'll start with the fact that default healthcare practices, which are oriented towards sustaining life, are probably appropriate, right? We want the 20-year-old who has a sudden cardiac death on the basketball court to be resuscitated. We want the 50-year-old with pneumococcal meningitis and septic shock to be intubated for airway protection and put on vasopressors if needed to treat his shock if he or she is unable to communicate. Those are reasonable default practices, and I'm not arguing with that at all. But the fact that they are our default practices, meaning that we will provide intensive care unless or until someone tells us to stop, means that that approach to medicine holds a privileged place. Some people will like to express contrarian preferences, meaning they don't want that default to hold sway. They'd like a different approach to their care. But inertia or inaction bias often prevents people from documenting their core goals and, in fact, prevents clinicians from engaging patients in expressing and documenting their goals. Another problem is that we as clinicians tend to focus on what I'll call preferences, and I always have a instinctual response to put this in air quotes, and sometimes on my slides it will actually appear in genuine quotes. And what I mean by this is to reflect, A, that these preferences that we tend to focus on typically have to do with the use or non-use of specific medical interventions, and not focusing on broader goals like health states that we would hope for, events in the future that we want to be around for. Those are probably the things we ought to be focusing on. And the other thing I intend by the quotes is that, as I'll show you with some data in a bit, these preferences are not particularly stable or deep-seated. They're highly malleable. They change over time because of that effective forecasting problem that I mentioned, and also because what people say they want is in large part a function of how we ask the questions. And then finally, when we do lose decisional capacity, our caregivers suffer from a number of biases, including over-optimism, and the prospect of loss aversion, where the idea that we might lose something that we currently have weighs much more heavily on our decision-making in the classic economic terms than the prospect of actually gaining something. But in relevance to end-of-life decision-making, the idea of loss focuses our goals on just getting to tomorrow, to tomorrow, to tomorrow. I don't want any doors foreclosed, which is often what palliation feels like. So absent strong preferences, decisions often get nudged. I imagine that at this point, almost everyone in the room has read or at least knows of one of these 3 books, and honestly, I could fill like 4 slide decks with the other titles of similar lay press books about behavioral economics. But there's maybe not one single definition of what a nudge is, but this is a definition that I think most would agree with, and is certainly the one I use. So a nudge is a decision-affecting feature of the choice environment or the architecture of the way in which choices are structured that has 2 key characteristics. One is it doesn't restrict options. If it did, then some people would call it a shove, not a nudge. And 2 is it doesn't materially change the incentives for choosing A versus B versus C, etc. So what I mean by that is, if we offer people money to do something, and in another hat I wear actually does just that, like offering people money, for example, to stop smoking, that's not a nudge. That's a classic economic incentive. And that doesn't mean it's useless, it just is a definitional matter. And choice architecture is really relevant for everything we do. If I remember correctly, this is a paper that Randy invited us to write in his role as an editor of intensive care medicine, one of the leading journals in our field. A guy named George Anisi, who at the time was a fellow, now is one of our junior faculty, took the lead. And we talked about some heuristics or cognitive principles that could arise in the context of focusing on whether or not we ought to do CPR. Now, I will say, I don't spend a lot of my time in the ICU focusing on whether people should receive CPR or not. I tend to focus more on broader goals of care, but every once in a while, you've got to do this. And I will tell you that the ways in which we frame these choices meaningfully influence the choices that patients or their caregivers will make. So just to go through a couple of the examples, you could play around with the default. You could say things like, in this situation, there's a real risk that, say, your father's heart may stop. And if it did, because of how sick he is, we would not routinely do chest compressions to try and bring him back. Does this seem reasonable? So people have the opportunity to object, ask questions, and push you on that, but you've changed the default paradigm. I will tell you, I do this all the time for patients who are on the brink of dying despite maximal medical therapy. And I've never once had a family choose CPR, not once. There are other cognitive heuristics that you could leverage. So you could reflect on social norms. Many patients in this situation would not want chest compressions if their heart stopped. Does that reflect what your mom would want? You're just norm setting. Like, people want to go with the wisdom of crowds, particularly when they don't have deep-seated preferences for themselves. And there are a variety of other things that you could do. I'm not going to go through the whole list, and this is not intended to prescribe to you how you should be having these conversations. I don't think there's necessarily one right or wrong way to do this, but the point instead is that you can't escape the influence you have as a clinician in guiding the choices that your patients and their family members make. You can't be entirely neutral. So, if we can't be neutral, maybe we can take advantage of these cognitive heuristics or errors, if you will. So one way in which we've sought to take advantage of this is by nudging people to complete advanced directives, whether traditional pen and paper or advanced directives or web-based advanced directives. What you see here is actually a web-based advanced care planning module called ourcarewishes.org that we've built at Penn, is now the standard advanced care planning approach that we advocate for our patients. It has a heavy focus on goals and a light focus on intubation, CPR, feeding tubes, etc., intentionally. And here's an example of a basic behavioral economics study that'll set the stage for the advanced directive nudging study I'm about to describe. So this is a classic paper by Amos Tversky, the late Nobel laureate, published in the early 90s when, I guess microwaves are still like an important part of daily life, but at the time, like getting the right microwave was super duper important. And what they did was they asked 60 people, do you want this Emerson, which is small and inexpensive, or do you want the Panasonic, which is bigger but more expensive? And as you can see, there was a slight preference. Majority, 57%, chose the smaller and cheaper option. But what they didn't tell those people initially is that there's actually a third. Oh, I'm sorry, I didn't show you the percentages. But then there's actually a third option, a Panasonic 2, that's even bigger still and more expensive. Now look, so what's interesting here? It's not that 13% want the really big one. It's that by showing them that there's actually a third choice, the preference between the first two switches. So under what paradigm of rational decision-making would your preference between A and B be influenced by whether or not C is an option? Right? That doesn't make any sense at all, but that's exactly how we all think, because we actually don't really know if we want if we want to pay a little more for a little more cubic feet of our microwave oven. We don't really have deep-seated preferences about this. And so if you give me the third option, now there's like these two extremes. I'm going to go with the middle one, right? Because that's satisfying like some Pareto optimal, in my mind, blend of size and cost. We can do this in healthcare. So this was a study that one of our superstar junior faculty, who Randy's been kind enough to sort of co-mentor with me, Kate Courtright led. This was actually her master's thesis as a fellow. She did a 316-person randomized trial of 2 different approaches to encourage patients with end-stage renal disease at 15 dialysis clinics in the greater Philadelphia area to complete advanced directives. And they got randomized to a standard approach where in the dialysis clinic and they hadn't had an advanced directive previously. We asked them, would you like to complete an advanced directive? And we'd hand them a form. They'd say yes or no. And the intervention group, same thing, except now we offer them, would you like to complete an advanced directive? They could say no. Would you like to complete a brief version, an expanded version, which had more clinical scenarios in which they could express their preferences for if they wound up in those scenarios, or a comprehensive version, which had more scenarios still? Now again, whether or not one wishes to complete an advanced directive at all should not really depend on the number of options. But in fact, it does. There is a significant increase in the proportion of patients who are willing to complete an advanced directive. Now, I will tell you that the the punchline here, if you will, is that this did not lead to a significantly increased rate of people actually completing what would be considered legally valid advanced directives, but that's a pretty high bar. We've discussed elsewhere, and Barak Gasser and I were having a nice conversation about the irrationality of considering advanced directives to be legal documents in which witnesses and notarization and all that has to happen. Like, they're clinical documents, come on. So there were barriers because this is a relatively low-income population that has less access to actually going ahead and completing it, but that wasn't really the goal. The goal was to prove the principle, which I think Kate did nicely. This is another study we did at Penn for new employees at the university. Now, I don't think this is the right population to look at for advanced care planning. These people haven't learned to live with serious illness, but again, this is just sort of a proof of principle concept that whether or not we complete an advanced directive is an entirely nudgeable phenomenon. So what we did is we took about 1,300 new employees at the University of Pennsylvania Health System, and we randomized them to a control or an intervention during what's called their onboarding process. So this is when, like, you complete your W-9, you make your 401k elections, you do your background check, and it's all web-based. We just added an advanced care planning module, but we did it in one of two ways. So the control way looks like this. We say this task is optional for completion of your onboarding process. We describe what an advanced directive is. We give them a link to click on for more information about advanced care planning. And then we give them two buttons. You can either complete an advanced directive or you can confirm that you already have one. And if you don't want to do that, you just skip through it because it's optional. Intervention, we said it's required. So again, you've got the option to complete an advanced directive on the left, to confirm that you already have one on the right, and all we did is we got rid of the skip button and we put in another button that says click here to decline the opportunity to complete an advanced directive. Now again, normatively speaking, under rational utility theory, this ought not make a difference. If you didn't want to complete it under scenario 1, you shouldn't want to complete it under scenario 2, and yet huge differences. Not only in the rates of people who completed an advanced directive online, 20% to 35%, but actually 4% versus 8% actually did the extra step, which we didn't even encourage them to do, of getting witness signatures and sending it back to us. Probably the strongest nudge across all settings is changing the default option. This is just one example of some work we did led by my colleague Mitesh Patel at Penn, where we changed all of the computer physician order entry systems in the outpatient practices of the University of Pennsylvania, such that if you typed in, say, Toprol, metoprolol, generic, would pop up. And there were buttons that you could click to get out of this and actually prescribe Toprol for your patients. But basically, we oriented the computer so that whatever name you entered, the generic would pop up, and then you had to do something extra to actually prescribe the trade name. And you can see that across almost all categories of drugs that were prescribed, somewhere between 50% and 90% generic at baseline, all but one went to 100% with this simple change, generic. What's the one that didn't? I find this to be a really interesting example. So it's actually levothyroxine. So why is that? I know you guys are thinking, because we all learned, maybe not all, I learned in med school, and I know nothing about endocrine, by the way, any longer, but I remember learning in med school that the pharmacokinetics of generic levothyroxine and trade name Synthroid were different. And so you can't just switch one for the other. I don't actually have any idea whether that's true. But that's not the point. The point is that some people believe it is true, and they opt out from the default when they think it matters, and that's a good thing. We don't want defaults to push everyone in one direction when there may be reasonable circumstances to go against it. Again, that would be a shove, not a nudge. So I like that counterexample. So now getting back to serious illness care. This was a study we did a few years back of 130 patients with advanced diseases of the thorax. And we randomly assigned them to complete one of three versions of a state-authorized version of an advanced directive. And these three versions were identical except for one key difference. The ways in which the overall goals of care to focus on comfort or focus on life extension were framed, and the ways in which the choices to receive, I think it was 4 specific interventions, a feeding tube, mechanical ventilation, CPR, dialysis, I think I got those right, the way those choices were framed. So all the options were available to everyone. And I'll just give you an example of sort of what this looked like. And people got randomized to one of three versions: a comfort default version, a life-extending default version, or what we call like a standard default where nothing is defaulted per se, such that if you don't make an active selection, you're effectively defaulting to surrogate decision making. So here's what the comfort default looks like for the overall goals of care. So you can see the top option is I want my healthcare providers and agent to treat me by helping relieve my pain and suffering, even if that means I may not live as long, and it's pre-selected. And then we say if you prefer to choose a different overall goal, just cross that out and put your initials beside one of the next two options. So the next one is the opposite. I want my healthcare providers and agent to treat me by helping me to live as long as possible, even if that means more pain and suffering, or I don't want to make a call at this time. So that's the comfort default. The life extending default had the first two options switched such that what's shown here as the middle would be on top, and that's pre-selected. And then the standard default, or what defaults to surrogate decision making, has all three listed in a randomly determined sequence to mitigate ordering effects, and nothing's pre-selected. Everyone kind of get it? When we get, I don't think I have a slide on this, but when we then frame the questions around, would you want mechanical ventilation? Again, in the comfort default paradigm, the choice I would not want mechanical ventilation is pre-selected, and you can cross that out, etc. You get the idea. So people completed this. They sent it back with witnesses or notary, like the usual shebang. And then we called them up and said, okay, here's what we did. Before we scan this into your electronic health record, which is what we told them we were going to do, so people knew these were real advanced directives, we called them up and said, so you got this version of an advanced directive, and it had this embedded default. Other people got these other versions, and it had these embedded defaults. Now that you know that, let's review every choice that you made to make sure it's actually what you intended. We went through every choice, their goals of care, intubation, CPR, etc. No one made a change at all after hearing that. And despite that, dramatic effects of the default options on the choices people made. So this is the overall goal of care. When comfort-oriented care was selected as the default, was pre-specified as the default, 77% of people stuck with it. When life-extending care was the default, 43% went against that default and chose comfort-oriented care. And when nothing was pre-selected, 61% chose comfort-oriented care. Similar effects for each of the specific life-supporting interventions, where what we're showing you here is the percent of people who opted to forego that intervention. Blue is where they were defaulted to forego it. Red is where there was nothing pre-specified, and green here is when they were defaulted to receive it. Big differences here as well. That doesn't tell me whether this is what we should be doing in advanced directives. All that tells me is that our preferences here deserve the air quotes, right? They're not deep-seated. If these were things that we knew and held deeply, they wouldn't be so easily nudged by a simple changing of the way in which the questions were asked, particularly when we just told people that that's what we did. So we did this follow-up study that's under review right now. This is just the protocol paper that I'm citing here, that was funded by the Gordon Betty Moore Foundation, where we sought to determine, okay, so does this intervention actually change outcomes that would be important to various stakeholders? Outcomes like the primary outcome of days alive and outside the hospital. Right? Everyone wants to live as long as possible, but also not to have the burdens of healthcare. So we chose this as our primary outcome with the idea that if this was ever going to be something that we'd put into practice, probably most people would want to show that the comfort-oriented default is not shortening that outcome or reducing that outcome. So we actually designed this as a non-inferiority trial on days alive and outside the hospital. But there are other key outcomes, quality of life, et cetera, costs of care that we looked at. And we followed people for a median of 2 years after they were randomized. So again, huge effects of the default option on the overall goals of care. Here in orange are the proportions of people who are choosing comfort-oriented care. Oh, and by the way, this is a much more diverse sample. This is heart failure and ALS and end-stage renal disease and pulmonary disease as well. So replicated the effects of the intervention on choices and confirmed the primary hypothesis. No difference in the number of days alive and outside the hospital by which advanced directive you completed, even though people chose different things. That's good. Here's what's not good. None of our secondary hypotheses in which we imagine that comfort-oriented care might improve some or all of these domains panned out. There were no effects of the advanced directives on any of these. So what do we conclude? Preferences for life support are not deep-seated at all, because we've now shown in multiple studies that what people choose is heavily influenced by how choices are framed. But if we can substantially change the distribution of choices that people are making in advanced directives, and it has no impact on long-term outcomes, that probably suggests that advanced directives, as currently instantiated in practice, are not useful interventions, even for seriously ill patients. And actually, this is the first experimental evidence on that question. There's only been observational studies, which basically compare people who decided to complete an advanced directive with people who decided not to. Like, you don't need to be an epidemiologist to understand the problems with that kind of study design. So this is fairly compelling. It's not perfect, but it's suggestive that for advanced care planning to achieve its promise, we got to rejig the entire thing. Like, it can't be the typical state-authorized forms. It's not going to get us to where we want. All right. So I've been talking about nudging patients. Now I'm going to talk about nudging you. Because we are a big part of this whole process/problem, depending on your perspective. So this is a trial that finished up last year that was conducted in 11 hospitals in Ascension Health, which is the largest nonprofit health system in the country with about 160 hospitals. I will say, like, for anyone following the news, this is the same health system that's partnered with Google on a relatively controversial data sharing AI plan. I don't want to get into that. That happened after the study ended, but just for transparency. So what we did is we picked 11 hospitals with mature inpatient palliative care consultative services and the same EHR, Cerner in this case. And we conducted a trial in which we randomly assigned the time at which each of those 11 hospitals would transition from a traditional opt-in approach to palliative care consultation versus an opt-out approach. And I'll describe what I mean by that. The patients we included had advanced stage COPD, advanced stage dementia, or end-stage renal disease on dialysis. I can get in later if you're interested why we chose those particular patient populations, but we also collected data on patients with advanced cancers and advanced heart failure to look at whether intervening on these three patient populations had spillover effects on those other seriously ill populations. And here's what the intervention, the opt-out intervention looks like. So instead of the traditional opt-in approach where, I'm caring for a patient on the hospitalist service, and I say, you know what, he'd benefit from a palliative care consultation, and I go ahead and order it. And then probably the consult happens. Instead, what we did is we built an algorithm to identify patients as meeting consensus criteria for patients who should have an inpatient palliative care consultation. And I'll highlight, those consensus criteria are totally not evidence-based at all, right? They're just standards. But that's what we had to use. And in fact, the goal of this is to evaluate the value of inpatient palliative care consultation for patients who are deemed appropriate for it. So what the algorithm does is it identifies patients as meeting those eligibility criteria. And if by 3 p.m. on the second hospital day, what we call day 1, with day 0 being the day of admission, if the docs had not ordered a palliative care consult, it would enter an order into the EHR automatically. But it wouldn't go to the palliative care team yet. It would be silent to them for the time being, for 24 hours specifically. Then, during that 24-hour period, anytime the primary service opened the patient's chart, they would be alerted that a system-generated order for a palliative care consult had been entered, and they were instructed on how to cancel it if they wanted, how to opt out. And if they didn't opt out by 3 p.m. on the next day, what we call day 2, then the order became live, went to the palliative care team, and then presumably if the patient was still in the hospital and the palliative care team wasn't too busy, they'd do the consult. So this was designed to see if we could, A, increase the penetration of palliative care consultative services to patients who we think ought to be getting it, and B, if we do in fact achieve that first goal, to then be able to evaluate, well, what's the value to patients? And value in this case, our primary outcome is hospital length of stay, which is the primary metric on which inpatient palliative care is justified and why institutions invest heavily in it, the prospect that it might reduce length of stay. And then we use, or we're in the process of using and developing natural language processing algorithms to try and identify these other potential benefits of palliative care, like documentation of goals of care, family meetings, assessment of pain, dyspnea, constipation, nausea, vomiting, etc. So this is exactly how it works. So like if you're one of the docs caring for a patient and there's a system-generated order, you're told about it, you go to your order entry screen, you select that order that's shown here, consult palliative care, you right-click on that and you get this list and you cancel or discontinue it. That easy. Well, it's not quite that easy. Then you have to enter a reason why. But you can enter any reason. You could say other and free text. It could be there are no palliative care needs at this time, or we're meeting all the patient's palliative care needs. It could be anything. Like you don't have to justify it, just pick. So unfortunately, this is an older slide. The study's over. We enrolled 34,000 patients in this trial, plus 25,000 patients with heart failure or cancer to look at spillover effects in. But with all that data, we're not quite at the analysis stages yet. But what we do know is that overall, under control opt-in approach, about 17.5% of people who we think should be getting palliative care consultation actually got it. And under the default approach, almost half got it. So almost a tripling of the rates of consultation just by flipping opt-in to opt-out. Now, why is that 50% not 100? Well, there are a couple reasons. There were rates of cancellation, as you'd expect, by the clinicians. They vary dramatically from hospital to hospital. Some hospitals, the docs canceled the system-generated orders only 2% of the time, and at other hospitals, it was a quarter of the time. And then the bigger reason is actually that any palliative care clinicians in the audience? So if you did, you'd be jumping up in your seats and screaming, like, how can you do this? We're already too busy. And indeed you are, right? They couldn't see all the patients. The patients would get discharged before they would rise to the top of the palliative care team's queues. And actually, that's the reason why we didn't choose heart failure or cancer, because we knew that had we done that, we would immediately overwhelm the capacities of the palliative care team. I will say that in planning for this study, each of the 11 hospitals did increase their palliative care services by 2 FTE equivalents, but even that wasn't quite enough. All right. I'm going to switch to another study that stems from the Choosing Wisely list that Randy and I and a number of other people were privileged to work on for all of the major critical care professional societies. And I don't want to talk about things like, don't transfuse when the hemoglobin's greater than 7, and don't, get daily chest x-rays for mechanically ventilated patients. You all know that. I want to talk about the more fun recommendation here, which is don't continue life support for patients at high risk for death or severely impaired functional recovery without offering patients and their families the alternative of care focused on comfort. So we're not saying withdraw grandma from the vent. We're saying offer the alternative. That's all this says. But the problem is it's actually hard to get docs to do this. And if you think about, I've just spent a lot of time telling you about how effective defaults are. You can't default this. Like, how would you design a system in which docs actually offered comfort-oriented care by default? That's really hard to do. So we need to dig into other tools in our behavioral economic toolbox to try and motivate this particular behavior. And here's the design of what we call the Ponder ICU study, which is conducted in Atrium Health, which is a 42 hospital health system in North and South Carolina and Georgia. Actually, it used to be called Carolina's Health System, but then they bought some hospitals in Georgia, so that was kind of weird, so they changed their name. So the design of this study is we take 10 of their hospitals and all the ICUs in those 10 hospitals, and we randomly assign the time at which they transition from usual care, shown in white, to intervention A in blue or B in red, and I'll tell you what those interventions are in a moment. And then after they're in intervention A or B for a while, they get the other one added. So we've got sort of a 2-by-2 design: usual care, intervention A, intervention B, and intervention A plus B. Got it? And these are the patients we're enrolling. So these are only ICU patients. Redaps was in all hospital patients. This is only in ICUs. Adults, mechanically ventilated for at least 48 hours, had at least one life-limiting illness. Again, the usual suspects: advanced heart failure, advanced COPD, dementia, end-stage renal, et cetera, at the time of admission. So a sick population. And this is intervention A. Well, it's not exactly intervention A. And I promise this is also not my prediction for all you Husky fans of like next year's BCS. This is, instead, one of my favorite studies by another Nobel laureate, Danny Kahneman, who got the Nobel with Amos Tversky, in which they looked at the question of whether living in California makes people happier. You'll understand where I'm going in a moment. Trust me, just stick with me. So what they did is they asked about 2,000 students at these Midwestern schools, University of Michigan or Ohio State, or at these Southern California schools, UCLA, UC Irvine. Where do you think a given high school senior will be happier? If they go to one of the Midwestern schools or if they go to one of the Southern California schools? And then they asked the same students to assess their own happiness. So what did they find? Well, as you'd guess, pretty much everyone, regardless of where they went to school, said, well, that high school senior would be happier if they go to Southern California. And then when they asked them to rate their own happiness, there were no differences at all. So why is this? Well, the framing of the question forces people to think about what's the big difference between the Midwest and Southern California? The weather, right? And this bright sunshine weather, oh, I'm going to be so much happier. And we forget about all the other things that make us happy as college students. I'm not going to get into all the things that made me happy as college students, but trust me, there are a lot of them, and they weren't all related to the weather. But we don't think about that because of the way the question is framed. And it turns out that docs have the same type of tunnel vision. So this is a study led by Alison Turnbull, who's a brilliant junior investigator at Hopkins, and this is a study that I think both Randy and I helped Alison with, where we randomly assigned about 630 intensivists to evaluate 10 clinical vignettes of critically ill patients. And they were the same 10 patients that all the docs evaluated, but the way in which, or the information we gave them was a little bit different. So the goal was to see if we could increase docs' self-reported rates of whether they would do that choosing wisely thing. Like, would they offer care focused on comfort? Just offer. And the control group is in orange here. We told the docs that the patient doesn't want life support if their prognosis is bad. The first intervention, which is intended to be sort of like a negative control, is patients want life support, we told the docs, regardless of their prognosis. And then the second intervention is, we didn't say much about prognosis or what the patient wanted, we just asked the docs to estimate the patient's prognosis. They didn't have to get it right, they just had to estimate it. And this is what we found. So the bad news. Telling docs what the patient wants didn't matter at all. So these are the 10 patients across the x-axis here based on their predicted probability by a multivariable algorithm of dying in the hospital. So these are sicker patients, and the y-axis is the proportion of docs who said they would offer comfort-oriented care. And there's some wiggle here, but in general you could see that the sicker the patients were, the more likely the docs were to offer comfort-oriented care, so that's good. But telling the docs that the patient didn't want aggressive care didn't matter at all. That's less good. But what did matter is that there was about a 50% relative increase in the odds that the doc would offer comfort-oriented care just if we forced them to estimate the patient's prognosis. A focusing effect. So can we leverage that? So that's what we're trying to do in Ponder. So the first intervention in Ponder takes advantage of this finding and is structured like this. So the docs and the APPs, these are not academic ICUs, they're docs and APPs, get this pop-up when they are rounding on a patient who meets the eligibility criteria. Do you think the patient will be alive 6 months from now, yes or no? If you say no, you're done. If you say yes, there's one other question. What do you think their overall functional status will be 6 months from now? And it ranges from no noticeable limitations in physical or cognitive function all the way down to bedbound and almost entirely dependent on others. That's it. That's all they have to do. Second intervention, intervention B, takes advantage of the principle of accountable justification. So this is the best example of this that I've seen in the medical literature, but there are many examples in the consumer and marketing literature where, in this case, Jason Doctor and Daniela Meeker, who are down at USC, did this great study of primary care physicians who were ordering antibiotics for upper respiratory tract infections. And one of the interventions, every time the doc ordered an antibiotic for a patient who had a diagnosis for that visit of an upper respiratory tract infection, they asked the doc to enter in a free text box why they're ordering antibiotics for an upper respiratory tract infection to justify the decision. If the doc really thought it was indicated, they could do it. But just that intervention, forcing docs to justify it, oh, and by the way, it becomes a part of the medical record, their answer, that's key, decreased antibiotic prescribing by 18% on an absolute scale. That's a big difference in terms of antimicrobial stewardship. So we're doing the same thing here in Ponder, intervention B. So docs in this intervention group get asked, have you offered the patient or his or her surrogate decision maker the option of care focused primarily on comfort during this ICU stay? If they say yes, they're done. If they say no, they've got to justify it. That's it. And then the final intervention group, of course, combines both of those. So some of you are probably thinking, like, a lot of this is really ethically nefarious, all this nudging, this is like tricky stuff, and this is a totally separate talk, and you're right to feel that way. But I just want to conclude by giving you one more study to think about. This was a study that another trainee led, Emmie Rubin, who's now at MGH, where we randomly assigned, go back to that, remember the Economist slide I showed you about the 200 hospitalized patients with serious illness and the states worse than death? This is that same cohort, 200 hospitalized patients with serious illnesses. And we randomly assigned them to either deliberate on their preferences for life support or to just respond intuitively. So how do we do that? How can you randomly assign that? Well, let me tell you what we did in the intuitive group. In the intuitive group, we said, we read them the vignettes, and before asking them, as we're reading it, we said, you have to remember this 6-number string. And you have to repeat it back to me before you tell me your preference for mechanical ventilation or antibiotics or whatever. And you have to respond immediately without giving it too much thought, just based on gut instinct. In the deliberative group, we said you can't respond immediately. You have to think about it for at least 1 minute, and if you'd like, we'll come back tomorrow. and get your preference. We didn't force them to keep a number string in mind, right? So this number string thing, if you're like what is that all about? This is a standard approach in the psychological literature that basically obviates the potential for deliberation. Like you can't do it, or I can't do it, right? Like I can't really deliberate on a meaningful decision if I've got to keep a 6-number string front and center in my mind. So you're basically precluding the possibility of deliberation. And we had some tests to ensure that it actually did do that, and it did. So we randomly assign it, and the idea here is, well, okay, like the idea that we can just get, if people just didn't respond so intuitively, then their preferences would be genuine. They'd actually make choices that really reflect their underlying goals. But that didn't actually work. There were no differences whatsoever in the probability that patients would choose feeding tubes or antibiotics or intubation or trach or other things, regardless of whether they responded intuitively or immediately, or they took their time and really thought about it. And worse, the people in the deliberative group were more likely to choose interventions overall that actually placed them in health states that they themselves had just said were states worse than death. So this is a really big problem for the field of decision aids, by the way. And it reinforces the notion that you can't just escape the influence that you have over people's decisions by asking them to think more. And Randy and Nancy Lau from here wrote a really nice editorial about this paper, and I just wanted to highlight this quote, which I love. Rather than supporting deliberation for the sake of patient autonomy, the goal should be making the best medical decisions with, and I love this part, or if they desire for, patients and their families based on the patient's values and goals. And if that isn't sufficiently compelling for you, and I think it ought to be, I'll just conclude with this one other quote. Most times when I go back and read papers that I was part of like many years ago, I'm like, ugh, did I really say that? I don't really agree with that anymore. This is a case where I actually still do. I was writing with 2 philosophers from Baylor, and we said, you know, inevitably, some choices will be presented first or as the default, meaning that the ethical task for the conscientious clinician is not to avoid influencing choice, it's just to avoid restricting choice. Thanks a lot. I'd be happy to take some questions.
Thanks for that talk. If patients and physicians are very susceptible to this choice architecture or nudges, how do we watch out for maybe bad actors? And you were talking about that a little bit, but I'm thinking about insurance companies that may have a different bottom line, and they could really, it seems like, influence care.
Yep, great question. So the bad actor problem. So I would say that that's a very real concern, and I don't have a perfect bulletproof way to avoid the overall problem, which I would characterize as the choice architects having ulterior motives. There's no perfect way to do this. In the context of when we think about this with patients and clinicians, and particularly clinicians, I think we have to rely on the typical standards that we always rely on in healthcare, that physicians are sworn by oath to act in their patient's best interest. There's no better solution than that. You brought up the example of insurance companies. I will tell you that it's been incredibly frustrating to me. We've tried to partner with many of the major insurers around the country around this, the nudging advanced directive completion and a few other things, and insurers are like, we love it, we think it could help us, but the optics of that, if it got out, like we don't want any part of that. So if anything, it's been frustrating to me as a scientist because I want to do the studies, but if anything, it's reassuring to the concern that you're raising, because I think insurers is a competitive marketplace, and they're very sensitive to the optics of things. And I think that's actually constraining what they do. That, again, isn't totally satisfying because it's not a bulletproof answer, but maybe provides a modicum of reassurance.
Hi, thanks for a great talk. As a primary care doctor, one of the things I really struggle with is that the person who is making decisions and having these conversations with me in a room in my clinic when they're in a state of like relaxation and health is actually a different brain than the person who's going to be making the decisions when they're in like a fight, flight, or freeze decision or a state of ill health. And it's hard for me to reconcile the fact that for all the work that we try to do in primary care to make sure that people's goals and preferences are understood, those goals and preferences, they can't imagine who they're going to be when they're sick, and they don't have like empathy for that person yet. And so it feels like a lot of those conversations are sort of like lost in the wind when someone actually gets to a position of being sick, because the decisions are extremely different.
Yep.
And that's not wrong, it just is.
Yeah.
Comment on that?
Yeah, it's a great comment and a thoughtful concern. So I don't know, does anyone listen to the podcast, The Hidden Brain? So The Hidden Brain's actually had 2 episodes on exactly this issue recently. One in which they interviewed George Lowenstein, who's a behavioral economist at Carnegie Mellon and a good friend, who has like pioneered the whole concept of hot-cold empathy gaps. And it's exactly this phenomenon you're eloquently referring to, that the decisions we make in sort of hot states are very different than the decisions we'd make in cold states. And it's not clear which are the right decisions. And then there was this other episode that was just like amazing to me, where they chronicled a nurse who like had always told her family, like, under no circumstances would I ever want any form of life support whatsoever. Like, I've done all these things to people and put them in all these terrible health states. God, just shoot me if I wind up with a serious illness, literally. And then she develops ALS, and her preferences are totally different, right? And that's real, and that's important, and that, if like, for all those people who are still saying, like, we should get the whole country to complete advanced directives, please, come on. I cannot think of a more ridiculous policy, because young, healthy people who have no idea what chronic serious illness is like have no capacity. If they enter their preferences and then that gets followed, it's at least as likely that we're going to be making errors than that we're going to be providing goal concordant care. So we really need to focus these conversations on people who've learned to live with serious illness, and then we just deal with the fact that as death becomes closer, and there's a psychologist at Stanford named Laura Carstensen who's really nicely described this problem. As death becomes closer, our values do change, and we need to accommodate that. But I would still say that if we change their elections through mindful nudging, then maybe those aren't real expressions of values, they're just expressions of fear or placating what the family wants or something like that. So I don't think it contravenes the or mitigates the responsibility of clinicians to nudge mindfully, but is a real issue that we need to, if we're trying to provide goal concordant care, we just need to acknowledge that.
Folks with additional questions can ask Dr. Halpern at the front, but let's give him one more big round of applause.